Hi, and thank you for joining us for this session on rare ovarian cancers. I'd like to thank our sponsor, the Gail Baird Foundation, for making this session possible. In this session, Dr. Rachel Grisham will discuss what's new in the landscape of treating rare ovarian cancers. Dr. Grisham is a medical oncologist at Memorial Sloan Kettering Cancer Center, where she's an associate attending and section head of ovarian cancer. She's also a former OCRA grantee. You can view her full bio on the conference website. Thank you for being here, Dr. Grisham, and I'll turn it over to you.
My name is Rachel Grisham, and I'm the section head of ovarian cancer and the director of gynecologic medical oncology at Memorial Sloan Kettering Cancer Center, Westchester. Thank you for having me today to talk about rare ovarian cancers, what's new, with a particular focus on recent advances and ongoing studies in low-grade serous ovarian cancer. Of course, there are different histologies of ovarian cancer. Most commonly, we talk about high-grade serous ovarian cancer, the most prevalent histology, which accounts for more than 70% of cases of ovarian cancer. Patients with high-grade serous ovarian cancer are more likely to have a BRCA mutation, have a precursor lesion that can develop from serous tubal intraepithelial carcinoma, or STIC. And in terms of genetics, most commonly have a P53 mutation, which is quite ubiquitous in this disease, present in more than 95% of patients. About 20% of patients will have some type of BRCA mutation, whether that be germline or somatic. And about half of our patients with high-grade serous ovarian cancer will have homologous recombination deficiency. There are multiple different drugs that we can now use to target high-grade serous ovarian cancer, including PARP inhibitors that are now used routinely in the frontline and recurrent setting, as well as other drugs which remain in clinical trials, such as WEE1 inhibitors, ATR inhibitors in combination with PARP inhibitors, and DNA PK inhibitors. There are, though, of course, other rarer histologies of ovarian cancer. Now, clear cell ovarian cancer and endometrioid ovarian cancer are grouped within the ovarian cancer disease, but really they most commonly arise from endometriosis, and because of that are more molecularly similar to endometrial cancer. They can be associated with HNPCC and really almost always originate in endometriosis, whether that's seen or not seen at the time of surgery. In terms of genetics, the most common alterations that we find in clear cell and endometrioid ovarian cancer include PI3 kinase mutations, ARID1A mutations, and PTEN loss. These are also the subtype of ovarian cancer that can sometimes be MSI high or MMR deficient, meaning more sensitive to immunotherapy. But again, that's because oftentimes it's not truly originating from an ovarian cancer precursor and is really originating from displaced endometrial tissue in the form of endometriosis. mTOR inhibitors can now commonly be used to treat this disease in the recurrent setting, and we also have clinical trials ongoing with ARID1A mutation targeting drugs. Mucinous ovarian cancer is a tricky form of ovarian cancer in that it can be hard to diagnose. Oftentimes, cases that are thought to be mucinous ovarian cancer actually turn out to be arising from a different primary under further pathologic review. So whenever someone is diagnosed with mucinous ovarian cancer, it's always very important to rule out that it's not actually a GI primary, such as an appendiceal cancer or a small bowel cancer. They can sometimes arise from teratomas in the ovary. The alterations that we most commonly see in mucinous ovarian cancer include KRAS mutations or HER2 amplification. And there are ongoing clinical trials looking at use of drugs such as trastuzumab and T-DM1 inhibitors for treatment of this disease. Low-grade serous ovarian cancer is the type of rare cancer that I'm going to focus on today. It's not known to be associated with BRCA mutations or any other hereditary risk. It has a precursor lesion called serous borderline disease that can be found in the pre-malignant state before advancing to low-grade serous ovarian cancer. While P53 mutations, which are very prevalent in high-grade serous ovarian cancer, are very rare in low-grade serous ovarian cancer, the alterations that we do most frequently see in this disease are MAP kinase alterations. So most commonly KRAS mutations that happen in about a third of patients, and also NRAS or BRAF mutations. There's been a lot of change in terms of the treatment of low-grade serous ovarian cancer over just the past few years. We now have MEK inhibitors that are a standard of care treatment for recurrent disease, and ongoing clinical trials looking at novel MEK inhibitors and MEK inhibitor combinations, as well as RAF inhibitors, which I'll talk more about today. So really, I'd like to focus on the molecular, clinical, and histologic features of low-grade serous ovarian cancer, what our current standard of care is in the upfront and recurrent setting, and recent clinical trials that have altered our treatment of this disease. Low-grade serous ovarian cancer and high-grade serous ovarian cancer used to be pathologically scored on a continuum of grade 1, grade 2, or grade 3 serous ovarian cancer. However, we now understand that they are two unique diseases, now called low-grade serous and high-grade serous ovarian cancer. They're clinically, histologically, and molecularly unique from each other. Low-grade serous ovarian cancer is more resistant to chemotherapy than high-grade serous ovarian cancer, though it does have response rates to chemo, both in the upfront and recurrent setting, and is really an area of unmet need. When we look at the comparisons between low-grade serous and high-grade serous ovarian cancer, we see that our patients with low-grade serous ovarian cancer are more often diagnosed at a younger age. And we see a surge in low-grade serous ovarian cancer in some very young patients in their 20s or 30s, and then another uptick in cases of low-grade serous ovarian cancer for women closer to the median age of high-grade serous ovarian cancer, women in their 50s to 60s. We most commonly see KRAS mutations within this disease, which occur in about a third of our patients. Another 10% will have NRAS mutations, and another 8 to 10% will have BRAF mutations, something that's really changed a lot about our treatment of this disease as we've better understood the molecular profile of these tumors. Now, I mentioned that it is more resistant to chemotherapy. However, low-grade serous ovarian cancer does respond to chemo, but it's not as exquisitely sensitive to chemotherapy as high-grade serous ovarian cancer, the disease which we compare it to most often. For patients diagnosed with high-grade serous ovarian cancer, the vast majority of patients, 80 to 90%, will respond to their initial chemotherapy when given in the neoadjuvant setting before surgery, while only 4 to 23% of patients will have a significant decrease in their cancer when first treated with chemotherapy for low-grade serous ovarian cancer. Similarly, in the recurrent setting, response rates to chemotherapy are lower for low-grade serous ovarian cancer than they are for high-grade serous ovarian cancer. Traditionally, endocrine therapy has been used in low-grade serous ovarian cancer much more than in high-grade serous ovarian cancer. Low-grade serous ovarian cancer is more likely to express the estrogen receptor as well as the progesterone receptor. More than 80% of patients with low-grade serous ovarian cancer, and in some studies, more than 95% of patients with low-grade serous ovarian cancer will be estrogen receptor positive, and about 60% of patients with low-grade serous ovarian cancer will be progesterone receptor positive. This has led to the routine use of drugs such as tamoxifen and aromatase inhibitors for treatment of recurrent disease, where we see a response rate of about 9% to endocrine therapies. Because of the relative good tolerability of these endocrine therapies, there had been a lot of interest in the use of endocrine therapy in the frontline maintenance setting following initial chemotherapy for low-grade serous ovarian cancer, similar to how breast cancer is treated, where patients commonly receive an aromatase inhibitor or tamoxifen after their initial treatment of breast cancer. A large retrospective study was performed by David Gershenson and his colleagues at MD Anderson that looked at patients with stage 2 to 4 low-grade serous ovarian cancer who had been treated at their institution between 1981 and 2013. This retrospective study compared those patients that had undergone initial surgery and chemotherapy, followed by observation alone, versus those patients that underwent initial surgery and chemotherapy and then received an endocrine maintenance therapy, such as letrozole or tamoxifen. They found a significant difference between the two groups, with a median progression-free survival, meaning median time until the cancer progressed, of 26.4 months in the observation group versus 64.9 months in the group of patients that was treated with the maintenance therapy. These were very exciting results and in many ways have changed our upfront treatment of low-grade serous ovarian cancer. where oftentimes for our patients with advanced disease, we will now consider the standard of care to be surgery, followed by platinum-based chemotherapy, followed by maintenance endocrine therapy, most commonly with letrozole. However, this has led to the question of, can our patients have just as good of outcomes if we treat them with the endocrine therapy alone and omit the chemotherapy? Since chemotherapy, of course, has significant side effects of its own, alopecia and neuropathy and fatigue and nausea and sometimes lasting side effects that we would like to avoid if they're not giving a clear benefit. To try to answer this question, there is an ongoing phase 3 study open throughout the United States and selected other countries called NRG GY019. This is a randomized phase 3 two-arm trial where patients are treated with paclitaxel and carboplatin chemotherapy followed by letrozole maintenance, or letrozole maintenance alone after they have had their initial surgery for staging of newly diagnosed low-grade serous ovarian cancer. Patients on this study are randomized 1-to-1, and it's it's unblinded, meaning that patients know whether they're receiving the chemotherapy followed by letrozole versus letrozole alone. This study is open at more than 500 different locations and continues to accrue. So while we continue to answer the question about the optimal treatment of newly diagnosed advanced low-grade serous ovarian cancer and whether it will be possible in the future to omit chemotherapy, the treatment of recurrent disease has changed quite a bit over the past few years, with particular interest in the use of targeted therapies for recurrent low-grade serous ovarian cancer and identification of biomarkers, which may help us to best choose which treatment to use for which patient. While high-grade serous ovarian cancer has a high level of copy number alterations and typically 50 to 70 somatic mutations per tumor, low-grade serous ovarian cancer and its precursor lesion, serous borderline disease, typically have less than 10 somatic mutations per tumor. So they're generally pretty stable tumors that don't frequently develop new reversion mutations or other alterations frequently during the course of one's disease. Because of the high prevalence of KRAS mutations and other MAP kinase alterations within this disease, there was interest in the use of MEK inhibitors for treatment of recurrent low-grade serous ovarian cancer, a targeted drug. The first study specifically looking at the use of MEK inhibitors for recurrent low-grade serous ovarian cancer was with selumetinib, an oral MEK inhibitor. This study enrolled patients with recurrent low-grade serous ovarian cancer who had measurable disease and could have had any prior number of prior therapies before they came on study. All of the patients on the study were treated with the oral MEK inhibitor selumetinib for as long as it was working until progression of disease. The study showed promising results with a 15% response rate, meaning 15% of patients had a shrinkage of their tumor of 30% or more. There was one complete response on this study and several partial responses with a median time until progression of 11 months. This study was done quite a while ago, and our DNA sequencing technology has changed since then. But at the time, DNA analysis was done through sequenome analysis, which specifically looked for hotspot mutations in KRAS or BRAF. And based on the limited tumors that were available from a subset of the patients enrolled on the study, that study did not find a specific association between mutation status and response to selumetinib. Interestingly, there were at least 2 patients that have been long-term responders to that initial study of selumetinib. One patient who was initially treated at MD Anderson Cancer Center started selumetinib in 2008 after having received multiple prior lines of therapy. She developed a partial response with calcified disease, and at several different times during the course of her ongoing treatment over the next several years, she had to hold her treatment for elective surgeries or other elective procedures. And it was noted that her cancer would start to grow when she was off of the selumetinib, but then get smaller again when she resumed the selumetinib. Another patient who was treated at Memorial Sloan Kettering Cancer Center, initiated selumetinib in 2009 after receiving multiple different lines of chemotherapy, including intraperitoneal chemotherapy and other targeted drugs, including endocrine therapy. That patient has had a complete response with no visible disease. She now remains on the selumetinib more than 10 years after first starting the clinical trial, and is a very successful clinical trial patient. Based on that patient, we were able to sequence the DNA from her tumor, which showed that she had a novel alteration affecting the MAP kinase pathway, which likely makes her uniquely sensitive to treatment with this drug. There's also been a lot of interest in the use of MEK inhibitor combinations that can help further increase the efficacy of these drugs, such as including MEK inhibitors with PI3 kinase inhibitors or other drugs. However, when combining these drugs, we can run into difficulty with toxicity. And so we always have to be thinking about what are the side effects of the drug, and will it be tolerable to combine the two drugs together, especially since we want our patients to be on these pills for a really long period of time, hopefully 10 years or more if they have a really good response. Well, MEK inhibitors in combination with PI3 kinase inhibitors have shown some really promising responses. We are still trying to find the right combination that will be tolerable for our patients. It has been found that single-agent MEK inhibitors from multiple different companies have shown impressive response rates in patients with KRAS mutant low-grade serous ovarian cancer, leading to particular interest in those patients with the KRAS mutation and whether they might be the most sensitive to treatment with these targeted drugs. It was also notable that in a study of the MEK inhibitor binimetinib in combination with paclitaxel chemotherapy that was performed in patients with both high-grade serous and low-grade serous ovarian cancer, all patients with alterations affecting the MAP kinase pathway experienced clinical benefit, suggesting that patients with these molecular biomarkers may be the ones most likely to benefit from the MEK inhibitors, though we certainly do see responses in patients without identifiable molecular alterations. There were two large phase 3 studies performed looking at the use of single-agent MEK inhibitors for our patients with recurrent low-grade serous ovarian cancer. One of them was GOG 281, which was a randomized phase 2-3 study to assess the efficacy of the oral MEK inhibitor trametinib in patients with recurrent low-grade serous ovarian cancer. This study randomized patients to treatment with either the MEK inhibitor trametinib or physician's choice of standard of care therapy, which could have been chemotherapy with paclitaxel or topotecan or pegylated liposomal doxorubicin, or endocrine therapy with letrozole or tamoxifen. And patients remained on those treatments for as long as they were responding to them or until they developed bad toxicity requiring them to stop. This study enrolled patients that had quite a bit of prior treatment, about half the patients that had 3 or more prior lines of therapy before they came on the study. Overall, the median number of months that patients were on treatment was 13 months for patients with trametinib versus 7.2 months for patients who were receiving standard of care with chemotherapy or endocrine therapy. So a significant improvement in the progression-free survival. Overall, the trametinib also had a higher response rate than the control arm. The response rate, meaning the amount of patients that had 30% shrinkage or more of their tumors, was 26% to treatment with the trametinib, versus in the control arm with chemotherapy or endocrine therapy, only a 6% response rate. Those patients with letrozole had the highest response rate of any of those control drugs with a 13.6% response rate. And next was paclitaxel with a 9% response rate. No patients responded to tamoxifen or topotecan. Overall, the trametinib was pretty tolerable. The main side effects that we see with trametinib are there can be significant skin rash, and that skin rash is an acne type skin rash. However, we've learned over the years of using these MEK inhibitors that the best way to prevent that skin rash is to use prophylactic regimens. And so when starting my patients on MEK inhibitors such as trametinib, I do always start them now with skin prophylaxis at the time that they start the treatment, usually with an oral antibiotic and also a topical skin cream. After that, other common side effects of MEK inhibitor can include fatigue, diarrhea, nausea, and in some cases, decreased cell counts. Another phase 3 study that was performed at a similar time as the GOG study is the Milo-NGOT OV11 study. This was a phase 3 study of a different oral MEK inhibitor, binimetinib, versus physician's choice of chemotherapy in recurrent or persistent low-grade serous carcinoma of the ovary or fallopian tube or primary peritoneum. This study enrolled patients both in the United States and Europe, and is actually the largest prospective clinical trial that has ever been performed in low-grade serous ovarian cancer, enrolling more than 300 patients. Patients again were randomized to treatment with either the single-agent MEK inhibitor binimetinib or physician's choice of chemotherapy. In this study, there were no endocrine therapies in the control arm. Patients received either pegylated liposomal doxorubicin, paclitaxel, or topotecan. This study did limit patients to having a maximum of 3 prior lines of chemotherapy. So overall, these patients had received less chemotherapy before they came on to the study. The study had an interim analysis performed in January of 2016 that showed that the planned PFS analysis, the progression-free survival analysis, crossed the predefined futility boundary with a hazard ratio of 1.21. At that time, the decision was made to stop the study. However, as there were no safety concerns, patients that were on treatment were allowed to continue on treatment until time of progression of disease. This study randomized 341 patients, 228 of whom received the MEK inhibitor binimetinib, and 113 of whom were randomized to physician's choice of chemotherapy. The updated results from this study showed that the response rate to the MEK inhibitor binimetinib and the chemotherapy were actually the same. About 24% of patients responded. So we see that this response rate of 24% is pretty similar to the response rate to trametinib. But the thing that's different in this study is that the response rate to chemotherapy is higher. This is likely in part due to the fact that this study enrolled patients who had had much less prior chemotherapy. Patients could have only had a maximum of 3 prior lines of chemotherapy, while in the GOG study, patients were more heavily pretreated. As a secondary endpoint of this study, archival tissue was collected when patients first enrolled into the study to undergo molecular analysis through Foundation Medicine. These archival tissues underwent sequencing to see what mutations were present in an individual patient's tissue. And about 33% of patients that enrolled to the study were found to have a KRAS mutation. Overall, it was found that the KRAS mutant patients had a longer progression-free survival when treated with binimetinib, 17.7 months versus 10.8 months for the patients without a KRAS mutation that were treated with the MEK inhibitor. The median PFS was also longer in the KRAS mutant patients treated with the standard of care chemotherapy, 14.6 months versus 11.5 months in the control group, but not statistically significant, suggesting that patients with recurrent low-grade serous ovarian cancer that have a KRAS mutation may have better responses to treatment overall, but in particularly stronger responses to treatment with MEK inhibitor. It was found in this study that the response rate for the KRAS mutant patients was 44% versus 19% in the KRAS wild type, the patients without a KRAS mutation. Because of this, there has been particular interest in really targeting these patients better and trying to improve upon this 25% response rate. The FRAME study is an ongoing phase 1 study being performed in Europe, looking at VS6766, a dual MEK-RAF inhibitor, which is an oral pill, in combination with defactinib, which is an oral pill that is a FAK inhibitor. This study has shown promising results in patients with recurrent low-grade serous ovarian cancer, particularly those patients with KRAS mutation, and showing response even in patients that have progressed after prior treatment with MEK inhibitors, such as binimetinib or trametinib. Based on the promising results of that phase 1 study, there is now an ongoing phase 2 study open throughout the United States through the GOG Foundation, and also open in Europe now through ENGOT. The GOG 3052 study, also called ENGOT OV60 or RAMP 201, is a phase 2 study of VS6766, which is a dual MEK-RAF inhibitor, alone or in combination with defactinib, which is a FAK inhibitor, for patients with recurrent low-grade serous ovarian cancer. This study is enrolling patients right now and is open both to our recurrent low-grade serous ovarian cancer patients with a KRAS mutation and also those patients without a KRAS mutation, as the combination has shown activity in both types of patients. Overall, low-grade serous ovarian cancer is a slower growing disease that is more resistant to chemotherapy than high-grade serous ovarian cancer and disproportionately affects our younger patients. There's an ongoing upfront study to address the role of chemotherapy followed by endocrine therapy versus endocrine therapy alone. I currently consider the standard of care for patients with advanced disease to be surgery followed by chemotherapy and then endocrine maintenance therapy. But hopefully this randomized phase 3 study will help us to answer the question as to whether chemotherapy can be omitted. Patients can live for 10 years or longer with recurrent low-grade serous ovarian cancer, but can have significant side effects from their disease. And therefore, it's important that we find better treatments for this disease and treatments that can treat our patients for many years without considerable toxicity. The presence of KRAS mutation may predict for those patients that are most likely to respond to MEK inhibitor or MEK inhibitor combination therapies. And so ongoing studies looking at targeted therapies are helping us to better molecularly stratify our patients and identify which patients are the best candidates for which treatment. Thank you so much for your time, and thank you so much for all that you do for patients with ovarian cancer.